for umpteen years, I've just used chalk and a blackboard to give this lecture, and it works fine with chalk and a blackboard, except that my handwriting and artistic skills have declined very dramatically over the last few years. So I got to work this morning. I said, what the hell, let's see if I can actually make it PowerPoint. You would probably be happier with chalk and blackboard. So this is not actually it's experimental in the sense that I just finished about 20 minutes ago. So I don't really think that it's all that well organized or the pictures are that great, but that's life in the big city. What do we already know? What have I already told you? There's a big difference between those two things. We know that the sympathetic innervation of the body wall, all the cell bodies that actually send their axons out, the synapse and smooth muscle and glandular material of the body wall, all those cell bodies lie in the paravertebral chain of ganglia. All the sympathetic cell bodies lie in the paravertebral chain of ganglia. And you're familiar with this diagram. Those cell bodies send their axons out either through ventral rami or dorsal rami spinal nerves. And the dorsal rami and ventral rami spinal nerves only go to the body wall. They don't go to any body cavity structures at all. They send no branches to body cavity structures. And they are controlled, these green postganglionic cell bodies for the body wall are controlled by preganglionic cell bodies in T1 through L2 of the intermediolateral column. So that much we know. We also know that when you're talking about the internal organs above the chest, the sympathetic postganglionic cell bodies lie also in the paravertebral chain. Also in the paravertebral chain, but between the superior cervical and the 5th thoracic ganglia. So the 3 cervical and the upper 5 thoracic ganglia contain the cells whose axons actually go in synapse on cardiac muscle, smooth muscle of the esophagus, smooth muscle of the aorta, glandular, probably not so much, but to the extent that glands of the bronchi get it, yes, certainly vasculature of the bronchi get it, and things like that. And that the postganglionic cell bodies, axons, don't travel in dorsal rami or ventral rami because dorsal rami and ventral rami don't send any branches to the chest in internal organs, so there's no point getting onto them. All right, they are just using the spinal nerve as a conduit to get to the ganglions. The preganglionics are, and the postganglionics travel in named organ nerves, the sympathetic cardiac nerves, the sympathetic esophageal nerves, the pulmonary, sympathetic pulmonary nerves, although these are all mixed together generally in one. So that takes care of everything above the diaphragm, all the body wall and all the internal organs above the diaphragm. Internal organs below the diaphragm, quite different. The cell bodies whose sympathetic, I'm talking about sympathetic now, the cell bodies whose axons go to the internal organs of your pelvis and abdomen and pelvis do not lie in the sympathetic chain. They lie somewhere else. This is a Netter drawing, which I spent all morning getting rid of little connections here. So it would look, because this is how, if I would do this with chalk, I would draw the aorta first and then I would draw these little white dots on it. So it took me a long time. At any rate, all of these ganglia, the ganglia that control, whose axons control abdominal and pelvic internal organs, lie on the front of the abdominal aorta, below the diaphragm. Some of them lie even below this is called the bifurcation of the aorta, when it splits into its 2 common iliac branches. Some lie below the bifurcation of the aorta, and then some lie on either side of the rectum. These areas here, these little white dots here, are the ganglia which lie on either side of the rectum. Now, in truth, some of them are big and you can see easily during dissection, and I will point those out. And some of these little white dots are in fact so small in reality that you would need a microscope or a dissecting scope to see them. They are called minute ganglia. But anyway, there's a whole bunch of them. The guy who I like, who wrote the book, calls these things the subdiaphragmatic ganglia. I think that's a great term. But there are at least 3 other terms commonly used to refer to these ganglia. Preaortic ganglia, they are often referred to, and that's because a whole bunch of them lie on the front of the aorta. Prevertebral ganglia, some people use that term, because they're all in front of the vertebral column, and these down here don't even have the aorta interposed between them and the vertebral column. And collateral ganglia is just a really old term, but you're bound to meet really old people in the course of your lives. And you have met one now, and you'll meet even more. And so you just have to be prepared that even though I like subdiaphragmatic, you may hear them referred to as pre-aortic ganglia, prevertebral ganglia, collateral ganglia. These are the sympathetic ganglia whose cells control abdominal pelvic organs. They get names depending upon where they lie in this whole chain here. There are a couple of really big ganglia around the origin of the celiac artery. I should have labeled this. And next, if I ever give this lecture again, we'll label it. By the way, maybe I'll just point to this so you know what I'm talking about. Celiac artery is right here. This is what you'll be dissecting today. The next artery down from it is the superior mesenteric artery, which goes to the midgut. When do you have to do the embryology?
That was last night.
Yeah.
Last night. Great. So you actually know that the superior mesenteric artery is the artery of the midgut. And you know down here is the inferior mesenteric artery. Right here is the artery of the hindgut. All right? There are some other arteries coming off the aorta that don't go to the gut, that go to retroperitoneal structures. Here are the two renal arteries, right and left. Here are some gonadal arteries, in this case look to be ovarian. But those aren't, I'm not concerned about those. I am concerned about celiac, superior mesenteric, and inferior mesenteric, the big three arteries that go to the gut structures. There is around the origin of the celiac artery these two ganglia. We'll see them, should see them in dissection at the very end of the abdomen and pelvis dissection, I believe. And they are called celiac ganglia. They are part of the subdiaphragmatic collection of ganglia. There's one, sometimes two ganglia around the origin of the superior mesenteric artery, and those are called superior mesenteric ganglia. These you can forget about. I don't care if you ever know this term. They are described. I've never seen them. Some ganglia right where the renal artery comes off. Here's the other one on the other side, and that's called aortico-renal ganglia. I should just wipe this out because I'll never ask you about that. And then there are the minute ganglia, which I've never seen, but which I believe exist. I'm not sure I believe the aortico-renal exists, but I believe these others exist. There is a collection of tiny, minute ganglia between the origin of the superior mesenteric artery and the origin of the inferior mesenteric artery, which are called intermesenteric ganglia. I probably will never ask you about them. There is a ganglion associated around near the origin of the inferior mesenteric vessel, which is called the inferior mesenteric ganglion. So this is not real hard so far. You know, celiac around the celiac artery, superior mesenteric near the superior mesenteric artery, inferior near the inferior mesenteric artery, and intermesenteric between them. Then below, and on the front of the aorta, below the origin of the superior mesenteric artery, and on the front of the sacrum, and this is the left common iliac vein, are these collection of minute ganglia, which you will never see, all the way up and down here on the front, which are called superior hypogastric ganglia. Superior hypogastric is a term that we will have occasion to use from time to time. So this whole long bunch of ganglia, minute, not dissectable except with a scope, below the origin of the inferior mesenteric artery are called superior hypogastric ganglia. And then there are some which hug the sides of the rectum. And the first group that hugs the sides of the rectum are called inferior hypogastric ganglia. And then lower down, and you'll see later why they changed their name, but they do change their name. The lower ganglia, which hug the sides of the rectum, are referred to as pelvic ganglia. So these are the names given to all of the different subdiaphragmatic ganglia who send their axons out to these organs. And this is what it looks like if you trace, this is, now I've just taken more Netter and altered it. You see that the celiac ganglia send their axons out to distribute along all the branches of the celiac artery to carry sympathetic to all of the foregut legion. And the superior mesenteric ganglion sends its axons out along all the branches of the superior mesenteric artery to do all of the midgut structures. And the inferior mesenteric ganglion sends out its axons along all the branches of the inferior mesenteric artery to do all of the hindgut structures. And then there's some other things, going to the kidney and going to other things here. And all of these down here on the superior hypogastric, inferior hypogastric, and pelvic are going to send their axons straight to pelvic organs. So I haven't drawn them in here because I don't have any pelvic organs. They don't even follow vessels. They just go straight to pelvic organs, all these hypogastric ganglia axons do. So we have now, just like we always do, we've figured out how every organ gets its sympathetic supplies from these ganglia. And in the cases of the midgut, foregut, midgut, and hindgut, the sympathetic axons travel out along the vasculature to reach the organ that's going to be innervated.
Which nerves are
You read my mind. The question is, what spinal cord levels control these ganglia? I've always started out with, let's look at the ganglia and then we'll figure out what controls them. Now we ask our question. Now the question has been asked, what controls these ganglia? Because something's got to do it. We can't let them go about doing whatever they want to without control. First, I'll answer directly your question. What spinal cord levels control these ganglia? And then we'll ask how that happens. The spinal cord levels that control the celiac ganglia and therefore control the foregut are T5 through T9 of the spinal cord in the intermediolateral column. All sympathetics lie between T1 and L2. So we know it's got to be within that range because that's where the sympathetic preganglionics lie, between T1 and L2 of the spinal cord. In the case of the celiac ganglia, it's controlled by T5 to T9. In the case of the superior mesenteric ganglion, it's controlled by T9 through T12. I'll give you a little way to help you remember this a little better, but there's no way to make it easy. And then everything below the superior mesenteric ganglia is controlled by T12 through L2. So the mnemonic that it's not much of a mnemonic, I must tell you, but this is T5 through T9 is 5 segments of the spinal cord. 5, 6, 7, 8, 9. T9 through T12 is 4 segments of the spinal cord. 9, 10, 11, 12. T12 through L2 is 3 segments of the spinal cord. 12, L1, L2. So it's 5, 4, 3. The number of segments of the spinal cord that control these things. And they always overlap by 1. So here are the 5 that do the celiac T5 through T9. Only 4 will do superior mesenteric, and it will overlap by 1. And only 3 will do all of the others, and it will overlap by 1. And that's just the general rule that I use to try and remember what segments control these different things. Now the question is, how do the preganglionic axons get to these ganglia from these regions of the spinal cord? T5, well, I won't repeat them again. They get to them, let's say this is T6 or T7 or something. They get to them through these things called splenic nerves. This will be true. You'll see these things all the way from T5 through L2. All the way from T5 to L2. You will see cells in the intermediolateral column who send axons out through the ventral root and the spinal nerve sensu stricto and into the ventral ramus like every other preganglionic axon in the world does. Goes to the chain just like every other preganglionic axon in the world. But unlike the ones which are involved in body wall, they will not synapse in these ganglia. They will not ascend in synapse or descend in synapse. They won't synapse in the paravertebral ganglia. Unlike those for thoracic organs, they will not synapse in paravertebral ganglia. They will actually leave the front of the chain and travel in their own named bundle, which is called a splenic nerve. A splenic nerve is essentially a nerve composed predominantly of preganglionic autonomic fibers. Preganglionic autonomic fibers. That has left, in this case, has left the chain and will descend from T5 through T12, have to descend into the abdomen to get to the ganglia that's going to innervate. If you're talking about splenic nerves from L1 and L2, they start out in the abdomen, so they don't have to pierce the diaphragm to get there. The ones above that have to pierce the diaphragm to get there. And it turns out, as this doesn't surprise anybody nowadays because the system is so screwy, that some of the T12 through L1 cells that go to the T12 through L2, some of the cells at T12 through L2 of the cord that go to T12, L2 sympathetic ganglia, some of the axons, I'm probably going to say this right, of the cells that lie between T12 and L2 of the intermediolateral column that are destined to participate in splenic nerves. The axons will enter the ganglia T12 through L2, but some of them will descend to lower lumbar ganglia and probably even to sacral ganglia, and then leave those ganglia without synapse as splenic nerves that emanate from the lumbar and sacral chain, and those are called lumbar splenic nerves. They don't, you may have a lumbar splenic nerve emanating from the fourth lumbar ganglion, but it didn't get its preganglionics from the fourth lumbar segment of the cord. It got its preganglionics from the second lumbar segment of the cord, which descended in the chain and just left. That's just the way these things do it. So, but it doesn't make any difference. A splenic nerve is a nerve composed predominantly of preganglionic autonomic fibers, and the ones we're talking about now are the ones which carry sympathetics and just leave the chain without synapse. So you've already seen one big splenic nerve. You saw the greater splenic nerve. That's the one that it emanates from T5 through T9. It emanates through the 5th thoracic through 9th thoracic ganglia. Composed predominantly of preganglionic sympathetics. You'll see in a second why I say predominantly. Travels down the chest on the sides of the vertebral column, pierces the diaphragm, this you'll see or are supposed to see in dissection, and it goes to the celiac ganglia. One on the left, one on the right. That's where the greater splenic goes, to the celiac ganglia. Then there are some smaller thoracic splenic nerves which emanate from 9, 10, which emanate from 10, 11, and 12. Lots of books will say that the splenic nerves which have passed through the 10th and 11th thoracic ganglia should be called the lesser splenic nerves. That one splenic nerve which passes through the 12th thoracic ganglia should be called the least splenic nerve. I know a lot of people believe it. The guy I follow says it's so variable that you really shouldn't be giving the name to anything as a least and lesser splenic. You should just simply say that there are these lower thoracic splenic nerves coming from T10, 11, and T12, and we'll never dissect them, we will never dissect them, but there are some that do. Those lower thoracic, but they've got it figured here, this is one of these lower thoracic splenic nerves. They do go to the superior mesenteric ganglia. Now, we know that the greater splenic carries T5 through T9. And the superior mesenteric ganglion is controlled by T9 through T12. So some of the T9 fibers in the greater splenic are going to pass right through the celiac ganglion and come around here and go to the superior mesenteric. Because it's just the way it is. Because of the overlap, some of the greater splenic axons will pass through the celiac and come down and synapse on cells in the superior mesenteric. So those two become connected, those two ganglia. Then the lumbar splenic nerves, and oh yeah, you can see them here. Here's a lumbar splenic nerve. It's a nerve coming from a lumbar sympathetic ganglion. Here's some more another lumbar splenics there. They all come off the front. We'll probably see them in dissection. And they are going to all the intermesenteric ganglia, the inferior mesenteric ganglion, and they send axons which go down and synapse in all of these superior hypogastric ganglia, or sometimes they'll pass through a superior hypogastric ganglion and synapse on an inferior hypogastric ganglion, or sometimes they'll go all the way through all of these and synapse on a pelvic ganglion. These lumbar splenics are the source, really, for all of the preganglionics, for all of the ganglia below, for the inferior mesenteric and below, are carried in these lumbar splenic nerves. So now, lower thoracic splanchnics are T10 through T12. They go to the superior sympathetic. But we know T12 is involved in some of these lower regions too. So some of the T12 axons in the lower thoracic are not going to synapse on the superior mesenteric, but are going to descend down to synapse on some lower ganglia here. The bottom line is, here's the bottom line on this. All of these ganglia are connected by preganglionics, which are trying to find the right ganglion to get to. So they're passing, some of them will synapse on a ganglion to which they first brought, just like the chain. Some will synapse on a ganglion to which they are first brought. Some will descend and synapse on a lower ganglion. And it manages to connect all of these ganglia with all of these nerve strands, carrying preganglionics, trying to find the right ganglion to synapse on. So instead of just a set of subdiaphragmatic ganglia, you have what is called a subdiaphragmatic plexus, a nerve plexus in which ganglia are embedded. Have we ever come across something like that before? I'm trying to remember. But it is, what you've got is a plexus of nerves, an interweaving of nerves, in which ganglia are embedded, the ones that we know, and that's called the subdiaphragmatic plexus. All right, that is, in fact, the entire sympathetic control of the abdomen and pelvis. These ganglia, postganglionics, go out. They're controlled by greater splanchnic, lower thoracic splanchnic, and lumbar splanchnic nerves carrying these segments. Midgut, T5 through T9, foregut, T5 through T9, midgut, T9 through T12, everything below midgut, which means hindgut and pelvis, T12 through L2. That's all the sympathetics. What about the parasympathetics to the abdomen and pelvis? So there are two sources of parasympathetics. You probably know that already. One, the vagus. Now, the vagus is a nerve which contains predominantly preganglionic parasympathetic axons. But since a splanchnic nerve is defined as a nerve which carries preganglionic autonomic axons, the vagus nerve is a kind of splanchnic nerve. It should be called, if I were in charge of the world, and if you all take a vote, make me in charge of the world, we will call it the cranial splanchnic nerve, because it's a splanchnic nerve, it carries preganglionic autonomics, but it comes from the brain. All right, so it's really the cranial splanchnic nerve. You saw the anterior and posterior vagal trunks, which the two vagus nerves contributed to. Those come through the esophageal hiatus of the diaphragm onto the stomach, and they will have the job of controlling everything above that blue line, meaning they will be controlling all of the abdominal structures of the foregut and midgut. They probably give something to the kidney too, but the parasympathetic innervation of the kidney is not very important. So the foregut and midgut are handled by the vagus. And the vagus has these preganglionic parasympathetic axons which go to the celiac ganglion. Will they synapse in the celiac ganglion? No. The celiac ganglion is a sympathetic ganglion. These vagal fibers will simply travel with all of the sympathetic postganglionics in the celiac plexus out to the bowel, where in the wall of the stomach, and in the wall of the proximal half of the duodenum, and in the wall of the spleen, and in the wall of the pancreas, and in the wall of the liver, all the things fed by the celiac artery, are the cell bodies, the parasympathetic cell bodies, on which the vagal preganglionics synapse. So these were all sympathetic ganglion I'm talking about. You know that parasympathetic cell bodies lie distributed in the walls of organs. So the vagus is simply using these nerves which are traveling all around the celiac artery as a conduit to get to the organs and the cells in the walls so that the preganglionic parasympathetics can synapse. And then the vagus, a lot of vagal preganglionics pass through the celiac ganglion and down to the superior mesenteric ganglion, where they pass right through it without synapse and travel along the superior mesenteric artery along with the sympathetic postganglionics to distribute to all the midgut structures. So now you're getting these branches of the celiac artery and the branches of the superior mesenteric artery have a very dense network of nerves around them. And those nerves are carrying postganglionic sympathetics and preganglionic parasympathetics derived from the vagus. And when you go to dissect it, it's very obvious. Well, even when you do your dissection today, even more obvious when you do the superior mesenteric artery. Sometimes it's hard to find the vessels because the network of nerves around the vessels is so dense that you think you just strip away before you get down to the actual artery itself. These are very great profusion of these nerves distributing along these two arteries. All right, the vagus pretty much ends here. So what now carries the parasympathetic preganglionic innervation for the hindgut and everything in the pelvis? And the parasympathetic preganglionic innervation for the hindgut and everything in the pelvis is handled by these things called pelvic splanchnic nerves that I may have mentioned or may not have, but I mentioned this thing. In S2, S3 and 4, sometimes S2, 3, 4, sometimes S3, 4, 5, of the spinal cord, in a region that corresponds in location to the intermediolateral column but doesn't produce a bump there, sit parasympathetic preganglionic cell bodies. And those parasympathetic preganglionic cell bodies send their axons out the ventral root into the spinal nerve sensu stricto, but they have nothing to do with the sympathetic chain. So, first of all, there is no white ramus here for them to travel in. There's no white ramus in the sacral levels, only gray rami. They just simply leave the ventral ramus independently in a bundle of nerve, in a nerve that emanates from the ventral ramus of one from S3 and one from S4, sometimes one from S2, sometimes one from S5, a nerve that's called a pelvic splanchnic nerve. A nerve composed primarily of preganglionic autonomic fibers. They are heading to ganglion cells embedded in the wall of pelvic organs or embedded in the wall of the hindgut, because the pelvic splanchnic nerves cover the hindgut and all pelvic organs. They are the parasympathetic supply for the hindgut in all pelvic organs. Here is a big mess from Netter, but I point out to you, you can barely see here, here's S2, S3, S4, and these things are the pelvic splanchnic nerves which leave the ventral rami of S2, in Netter's belief, 3 and 4, and join, actually, the pelvic portion of the sympathetic, of the subdiaphragmatic plexus. That's how, in fact, how you define. That's how you know when inferior epigastric changes its name to pelvic, is the part of the subdiaphragmatic plexus to which the pelvic splanchnic nerves go is called the pelvic part of the subdiaphragmatic plexus. So the part above that on either side of the rectum is called the inferior hypogastric part of the plexus, and then the part which is superior to the rectum is called the superior hypogastric part, as far as the inferior mesenteric artery. So this being the part joined by pelvic splanchnic nerves, I know this by definition is the pelvic part of the subdiaphragmatic plexus, and this being the part on either side of the rectum, but not joined directly by pelvic splanchnic nerves, I know is called the inferior hypogastric part of the subdiaphragmatic plexus. This is just a reminder that the vagus handles everything from the stomach all the way through the small intestine, ascending colon and transverse colon, those are all midgut things, and the pelvic splanchnic nerves bring preganglionic parasympathetics to the hindgut, which is the descending colon, sigmoid colon, rectum, and everything in the pelvis itself. Now, we've got lots of nerves moving back and forth in the abdomen and pelvis. And we know that some carry preganglionic parasympathetics, some carry postganglionic sympathetics. Lots of these things are traveling up and down to find the right place to go to. And in addition, we also know that the pain of abdominal pelvic organs travels backwards just like it does everywhere else with sympathetics. So every nerve that I've drawn, here's an example of let's say the greater splanchnic contribution to the greater splanchnic nerve going to the celiac ganglion, who sends its postganglionic to the stomach. Well, there's going to be a sensory axon who terminates in the stomach, and that sensory axon is going to travel backwards along the celiac plexus of nerves. That's the plexus all around the celiac artery. It's going to travel backwards along the celiac plexus, and that sensory axon is going to pass right through the celiac ganglion. No synapsing going on here with sensory stuff. Travel back in the greater splanchnic nerve, go through one of the ganglia that contributes to the greater splanchnic nerve, T5 through T9, go through the white ramus of that ganglion, and then travel all the way back to the spinal cord. Because every time you can draw a sympathetic pathway out to something, running right alongside those sympathetic axons are visceral sensory axons traveling backwards. So this now the explanation for why the nerve plexus, by these nerves that you're going to dissect, are so thick and profuse, because they can contain not only autonomic stuff, but also a lot of visceral sensation from the gut. Now, it is true, what I just said, that visceral sensation from the abdomen and pelvis travels backwards along sympathetic. Yes, sir. You have to yell out, otherwise I'm not going to pay attention.
Sorry, I'll wait. What's the ganglion on the aorta called again?
This case, since this is the stomach, the ganglion that controls the stomach is the celiac ganglion.
Okay, thank you.
The one around the celiac artery, because the stomach is a foregut structure. You just have to know whether you're talking foregut structure, midgut structure, hindgut structure, to know what ganglion you're talking about. So this is the celiac ganglion, which there's a reason to do embryology, honestly.
One more question.
Oh, all right.
So the afferent, the visceral afferent, it doesn't go through the gray lines?
No, they follow the exact path of the sympathetic out. And since the sympathetic to the abdominal pelvic organs does not make use of gray rami communicantase in any way, because the only purpose of a gray ramus communicans, is to send postganglionic axons out to the body wall. So there's no reason for anything that's not innervating the body wall to use a gray ramus communicans. This doesn't go through it.
Visceral body wall, right? Not.
Visceral what? Visceral body wall structures, right. Obviously just visceral body wall structures, sweat glands, erector pili muscles, and the vasculature of vessels. So, and what I said about visceral pain from abdominal pelvic organs traveling the reverse route of the sympathetics, which we know is true for thoracic organs, and we know is true for body wall things, there's one exception, and that is the visceral pain associated with distension of pelvic organs. That is, when your urinary bladder starts to get too full of urine, or your rectum starts to get too full of feces, or your uterine cervix starts to get stretched by the head of a baby coming down it. When it's a distension of a pelvic organ, the pain does not follow the sympathetic pathway backwards. It follows the parasympathetic pathway backwards. So here's a bladder, stylized, and here's the sensory axon, which tells you that you have too much urine in your bladder, and it runs along the parasympathetic route back. So it goes on a very short, there's really essentially no postganglionic dissectable nerve. It goes, through or next door to the postganglionic cell body here, embedded in the wall of the bladder, travels on a pelvic splenic nerve to S3 or S4, and then travels back to the spinal cord. All right, so now that's it. Then there is no more, I'm not through here obviously, but there's no more to learn about this. We've covered the entire sympathetic supply of the abdominal pelvic organs, we've covered the parasympathetic supply, and we've covered the visceral sensation from them.
Is the on the dorsal horn are the viscerosomatic striations?
Yes. First of all, well, you know, a couple of things. Yes, there are viscerosomatic laminae in the dorsal horns at T1 through T12. Well, actually more than T1 through L2, rather. More because it turns out, I mentioned it in passing a couple of times, but you have so much to learn you probably don't remember. Visceral pain axons, when they get into the spinal cord, may synapse right where they're brought, but they usually split into, the axons usually split into branches and send one branch up the cord, one branch down the cord, and synapse over a fairly long stretch of the cord, so there are these viscerosomatic layers, even outside T1 through L2, and obviously down here as well. Now, this is what this is. I just want to, because it never hurts to go over this stuff a couple of times. I'm just going to trace out for you, although you could probably do this yourself. The sympathetic, I can trace out the parasympathetic too, but it's too easy. The sympathetic innervation of the gallbladder. Sympathetic innervation of the gallbladder. First question I will ask you, Chirag, since you are a wise ass, just tell me, this is such an easy question if you did embryology. If you didn't do it, it's not going to be easy. Is a gallbladder a foregut, midgut, or hindgut structure?
Foregut.
Good. Foregut is the correct answer. So we know that the foregut is handled through T5 through T9 of the spinal cord. All right? I told you that. Turns out that the more proximal parts of the foregut, like the abdominal portion of the esophagus and the upper half of the body of the stomach, is mainly in the 5 through 6 part. And the distal part of the foregut, which is the second part of the duodenum, plus all of those things which grow out from the second part of the duodenum, like the gallbladder and the pancreas and the like, in embryogenesis, is more towards the T7 through T9 side of the range. So in fact, T7 through T9 of the intermediolateral column of the spinal cord is the place wherein resides the preganglionic cell bodies for sympathetic control of the gallbladder. It has to be in the foregut region, and it's behind the back part or the low part of the foregut region. The preganglionic axons travel out through the T7 through T9 ventral roots. I'm telling you stuff you are going to say, yes, it's obvious. And then they travel out the preganglionic sympathetic axons into the T7 through T9 spinal nerves, sensu stricto. Then they travel into, I need the other blackboard, into the T7 through T9 ventral rami. Then they travel from the T7 through T9 ventral rami in the T7 through T9 white rami communicantes to reach the T7 through T9 paravertebral ganglia. And then the question I ask you is, what do they do next? Got them to the T7 through T9 paravertebral ganglia. Do they synapse there? No, everybody knows the answer. That's marvelous. They do not synapse there. They go right through them, right through these ganglia, and emerge from the anterior surface of these ganglia in contributions to the greater splenic nerve, which you saw in dissection. And preganglionic sympathetics travel in the greater splenic nerve. They pierce the abdominal diaphragm to enter the abdomen. And they there run to, since we're talking about a foregut structure, to one of the celiac ganglia. I'll just write. There are usually 2 or 3 of them. I'll put just celiac ganglia in there. Do they synapse there? Yes, everyone is saying, and they're absolutely right. Well, some people shook their head yes, so that's good enough for me. All right, there they synapse. Because these ganglia are sympathetic ganglia. And the postganglionics then travel out along vessels you will dissect today. At first, the postganglionics travel out alongside, on the outside of the celiac trunk. But the celiac trunk gives off an artery called the common hepatic. And the nerves around, the nerves that envelop the celiac trunk, that's referred to as the celiac plexus of nerves. The nerves that leave the celiac plexus and travel alongside the common hepatic artery is referred to as the common hepatic plexus of nerves. And the common hepatic artery gives rise to a proper hepatic artery, usually. There's variation, which we'll probably see in lab today. Proper hepatic artery, which is surrounded by a proper hepatic plexus of nerves. And the proper hepatic artery gives rise to a right hepatic artery, which is surrounded by a right hepatic plexus of nerves. And that plexus is carrying these postganglionic sympathies. And the right hepatic artery gives rise to an artery called the cystic artery, which goes to the gallbladder. And that is surrounded by a cystic plexus of nerves. Of course, the plexes are getting smaller and smaller. And the cystic plexus of nerves enters the wall of the gallbladder and innervates its smooth muscle and its glandular structures. So this is the sympathetic supply to the gallbladder. The pain from the gallbladder that arises when it becomes inflamed or when it goes into a cramping kind of contraction. If a gallstone is stuck in your bile duct and the gallbladder is contracting like mad to get it out, that causes pain. As you know, cramping causes visceral pain. Just follows this backwards. To this point, and then deviates into the spinal cord. What does this tell you about where you would expect referred pain from gallbladder attack? You would expect it in the T7 through T9 body wall. And in fact, that's where you find it, generally on the right side, distributed in the 7th through 9th intercostal spaces. Person feels a pain, usually radiates, starting in the back and radiates just deep to the angle of inferior angle of your scapula and radiates around the right side and ends up on the front somewhere. And that is not all gallbladder pain, all gallbladder diseases are accompanied by referred pain. But when they are, that's where you feel it, along the T7 through T9 body wall. Sometimes you feel it in your right shoulder too. That's a big mystery as to why that would be the case. The shoulders, and a lot of people believe that the phrenic nerve goes and does either sends a branch to the gallbladder. It's never been proven. And other people say it's due to the inflammation of the diaphragm. When the gallbladder gets inflamed, the diaphragm gets inflamed, and then diaphragm is C3 through C5, so you can get pain in the shoulder as well. Yeah.
So the green arrow, that's one single
axon.
So that goes straight to the dorsal root ganglion, right?
It goes straight to the dorsal root ganglion.
So, and then that will then synapse with one.
What we're looking at, say again?
And that will synapse with one nerve fiber that goes to.
Doesn't synapse in the dorsal root ganglion. Because this is just the peripheral process of a single axon that came out of a dorsal root ganglion cell. There is no synapsing going on in the dorsal root ganglion. This will travel will travel right into the central process, and that'll take it into the spinal cord where the first synapse will occur.
Okay, where does that synapse occur? In the spinal cord?
Synapse occurs in the viscerosomatic laminae of the spinal cord gray. So, and in theory, you can do this for appendicitis. Appendix is T10. So the appendix is a midgut structure. The midgut, as you know, is T9 through T12. Turns out the appendix region of the midgut is mainly T10, and you could trace its sympathetics all the way out, but along now, not the celiac plexus, but along the superior mesenteric plexus, and the pain would come back to T10 of the spinal cord, and the referred pain you get from appendix is T10 region of your body wall.
So the referred pain we should be looking at at dermatomes and kind of figuring out.
Yes, you should be looking at dermatomes for referred pain. All right, so this is almost ending, but not quite ending. And that's because we have all, this must, original sin. Because of original sin, things are never as simple. I'm going to say this, you're going to think that I'm stupid. Things are never as simple as I make them. All right? I think this is all a pattern, and I've thought about it long enough, and it makes sense to me. The fact is, I've given you general rules saying, foregut should be T5 through T9. Midgut should be T9 through T12. Hindgut and pelvis should be T12 through L2. All right? And all the pain that travels backwards along sympathetics should return to those segments of the spinal cord. The fact is that the most well-studied visceral pain in the world is the visceral pain from the uterus that arises during labor, the first stage of labor, which is a sustained, prolonged uterine contraction, which is very, very painful. Here is, just to show you, this is nothing that you haven't seen. This is here to remind me to talk about the uterus in a pregnant person. Here's the celiac ganglion. Just in this picture is the superior mesenteric ganglion. Hard for me to see. Here's the inferior mesenteric ganglion right here. Here are all the plexus bundles. Here's the greater splenic coming down like that to the celiac ganglion. Here's the superior hypogastric plexus, the inferior hypogastric, and then this is the pelvic plexus, the part of the subdiaphragmatic plexus joined by these things which are pelvic splenic nerves. And of course they distribute all the way out to the uterus. So the first stage of labor is the worst pain, and that is the pain that arises from a sustained uterine contraction. We should, based on what we know, deduce that since all the sympathetic, and this is a sustained contraction, it is not a dilatation, so we don't have to worry about traveling backward on parasympathetics. It travels backwards on sympathetics like all other kind of visceral pain does. We should deduce from all we know that since a sympathetic supply to the pelvis is T12 through L2, that this pain should travel backwards to the T12 through L2 part of the cord. But in fact, it doesn't. Because the sympathetic supply of the uterus is probably not really T12 through L2, it is probably really T10 through L1. This is just, there are so many violations of the rules I give you that I almost worry that I shouldn't be telling you the rules, all right? But you have to have something to organize this in your mind, otherwise you go crazy. But the one exception, and there may be other exceptions. The gallbladder is not an exception. The appendage is not an exception. So those are pretty good. And there may be other exceptions than the uterus, but I don't know about them if they exist. But the uterus is one you absolutely have to know because it's the most important visceral pain in the abdomen and pelvis. And that is that pain from the uterus in the first stage of labor travels backwards to T10 through L1. On every one of these electronic quizzes that you will take, on every exam that's ever been given in this course, you are asked to what level uterine pain goes to. So no, the answer is T10 through L1. And that's when you do a lumbar epidural, that's what you are trying to anesthetize. The spinal nerves, the dorsal roots of the spinal nerves entering at T10 through L1. And you put in a little anesthesia. You go in a lumbar puncture, but that's down well below where you want to be. And you thread a catheter up, higher up, and you bathe what you hope are the T10 through L1 dorsal roots in anesthetic. Outside the dural sac. You're outside the dural sac, but you know the roots are outside the dural sac. And you bathe that anesthetic, and that will, if done properly, eliminate the pain of the first stage of labor. Now, how would you even know if you have done it properly? If you are successful in anesthetizing the T10 through L1 dorsal roots, then the body wall will also be anesthetized at that level. You're only doing it to stop the pain of labor, but you will know if you've done it correctly if the body wall at T10 through L1 is also anesthetic. Anybody know where T10 goes to on the body wall, the dermatome? Yeah, the belly button, umbilicus. L1, mons pubis in a woman. So if you test that you've done it correctly by taking a little stick or something, and poking, or you can just ask the person, do you feel this? I mean, I don't know why I said poke, because you just say, do you feel this? Do you feel this? And you touch the skin on the anterior abdominal wall between the belly button and the mons pubis, and hopefully the woman says, no, I don't feel anything. And then you know that you have covered the right region. If she says, oh yeah, I feel a little down here when you're touching, she won't my mons pubis, but she said when you're touching down there, then you know that you've got to put in some anesthetic a little lower down. That you haven't covered enough. And if she feels the belly button, then you know you've got to put some a little higher that you haven't covered enough. If you do this correctly, yes.
How would you do it higher or lower if you're just doing
It's where you put the catheter. You can throw the catheter a little higher and do it lower, or pull it down a little lower and do it. If you do this correctly, and you only anesthetize T10 through L1, you have not anesthetized any of the nerves that do the lower limb muscles. So in fact, a person can walk, right? And do all sorts of normal activities and still be free of the first stage of labor pain. Now, you'll learn later that when the baby is getting squeezed, you must know this, when the baby comes out, it stretches all the tissue, stretches the cervix of the uterus, stretches the vagina, and stretches the perineum, all right, the vulva. Now, those are not, the dilatation of the cervix is handled by S2 and S3. That's a stretching pain. And the stretching of the tissues of the vulva as the head is coming out, that's a somatic pain. So that's also, and you will learn that the vulva is innervated by S2, 3, 4 nerves going to the body wall of this region. So you're not eliminating all the pain of having a baby when you do this. You're just eliminating pain of the first stage of labor. If you want to eliminate all the pain, then you have to put in your anesthetic down and cover the sacral region as well. And then the person can't really walk anymore because you're getting the nerves which do the lower limb. So that I don't know any more about the autonomic nervous system, so you can be thankful that I don't, because you have to sit through another one of these again.